As Suni started to kind of share with you all, the goal here is to really pull back the curtain, kind of share what does this look like? How do we and other teams like ours think about or synthesize, identify these goals of care? And so that always starts with the first conversation, the initial consult. This is kind of our framework for an initial consult, and most teams or many teams have a pretty similar framework. It starts with, tell us about your child. Tell us about who they are as a person, what makes them happy, what have you noticed about their personality. If this is an infant, we might ask, how did you choose their name? We really want to get a sense outside of the medical kind of diagnosis, who is this child and how do they fit into your family? Then, as we kind of talked about before, we want to get a sense of what's your understanding of what's going on with the clinical condition? Or what have you kind of heard from the teams? The goal here is really so that we start from a place of shared alignment in this prognostic understanding. Given that, what is feeling most important? What are the things you're hoping for? Maybe in the short term, in the longer term. And on the flip side of that, what is keeping you up at night? What things do you worry about? These two middle questions really help us target in on kind of those values and those priorities that help give us context to how are we going to think about the next steps and what's most important. And because we are an interdisciplinary team coming from different lenses, thinking about not just the patient, but also the family and the community, we really want to know kind of where do you find strength, what is helping you now, and how are you getting by day to day. Given there's so much uncertainty, as Suni was describing, in a child's medical course, particularly in heterotaxy, we try to consider what inflection points might arise. These are time points where palliative care involvement may be additionally helpful, and there are also time points when, if palliative care is already involved, we might take a step back, reassess those values and priorities that we uncovered and discussed in the prior initial consult or conversation. In this population, we might think of some inflection points, often starting with diagnosis, whether that's prenatally, early in infancy, at first surgical staging. Other inflection points we think about might be when the physiology has become more progressive or unstable, despite a staged intervention. And we also think about recurrent admissions, kind of due to the complexity and full body involvement of heterotaxy, or even transfers between and out of care units. Finally, inflection points that we think about are often when the anatomy seems no longer repairable, or cure, as we're calling it, is no longer possible. During all this, symptoms of advanced heart disease may drive additional step-back points. This brings us to this domain of decision support. So how do we get there? These goals of care that we've been talking about, particularly during inflection points, are really important. So we consider how to support families in decision making and offer or support the teams in offering clear medical recommendations that are based on identified goals and values. So, how do we do that? We often package what we've heard from families as goals into 3 buckets. Though we recognize, of course, that every family is unique and that these buckets are more on a spectrum. As our former fellow, Dr. Amy Porter, wrote in her 2023 paper, she helped kind of delineate this. On the one side of the spectrum is this idea of living as long as possible. And on the other side is living as well as possible. And we find many people end up somewhere kind of in the middle of living as well for as long as possible. Understanding where families' priorities and values are then allow us to consider decision-making frameworks, focusing on what matters most. So for the family, where living as long as possible is most important, decisions and support around decision-making focuses on this primary goal of long-term survival. And the risk of side effect and symptoms may not outweigh a potential kind of intensive intervention, the potential benefit of an intensive intervention. Whereas for a family whose focus is more on living as well as possible, decisions might focus more on optimizing quality of life and even discontinuing interventions that may cause suffering, recognizing that time might be shorter. And finally, for that middle group, where most and many families end up falling, where living as well as possible for as long as possible is most important, this is where we think a blended approach to care works quite well, where each decision is made by weighing the anticipated benefits and burdens over time and considering kind of time-limited trials. We know from the literature, this particular study was published in 2017 by a group of surgeons, that when there are high-stakes surgical decisions at play, using communication frameworks like this one, which is a best case, worst case, most likely, actually changes communication, shifting the focus of decision-making conversations from an isolated surgical problem to a discussion about treatment alternatives and outcomes. Given our field is so communication-driven, we collaborate with the surgical and cardiology teams to help structure challenging conversations to promote shared decision-making, particularly in the acute setting. This idea of shared decision-making, we have more and more kind of understanding over time about how important it is, and that it may help reduce regret. In this study, which is published in 2023, Elizabeth Broden, who's a nurse researcher actually here in Boston, she asked bereaved parents to report whether they had decisional regret and gave them space to describe their response in more qualitative detail. The language parents who had regret used often contained phrases like, I should have. Should I have? Was there anything more? It hinted at an experience of self-blame in decisions made for their child. Meanwhile, parents without regret referenced a shared responsibility. They conveyed phrases like, we were guided to, we followed the recommendation of, we shared in this decision, we trust. And so part of our job as palliative care clinicians is to support this decision-making, ensure it's aligned with family values and preferences, and to help provide recommendations that, given this evidence, promote shared decision-making. You might hear us say or support a team member in saying, based on what you've told me about what is most important to you and your family, and what I know about this disease, I'd recommend. Shifting gears just a smidge. thinking about other kind of domains of subspecialty palliative care. SUNY highlighted, started with this, but I think another space for us to think about is symptom management. And really here, we assess and manage physical, psychosocial, spiritual, and existential symptoms, and we tailor the approach to patient and family goals. We work in collaboration with other teams within the hospital and outside the hospital, and we have an expertise in end-of-life anticipatory guidance, assessment, and management, all again based on these goals of care, values and priorities.